Hello students, good afternoon. I hope your NEET PG exam went well. I am Dr. Khushbu Mahajan, your dermatology teacher, and today we will be discussing recall questions from dermatology. So finally, I'm really happy that your NEET PG has been done, and I'm sure you all will now be coming out with flying colors. So before we proceed with the recall session, just a little information. We have our rapid revision 6.0 which is being launched on 16th August, and this is with English video lectures. So kindly take advantage of that. What's in it for you? We have 260 plus hours of video lectures, 2500 high yield MCQs and concise notes. So all in all, a great way to prepare yourself for your exams. So now coming to the recall session, these questions which are being discussed in this PPT are recall based, and the motive of this session is just to get the actual questions for the exam. So don't start marking yourself based on whatever I discuss, because probably what I tell you, the images may not be exact what you got in the exam, or the options may not be exact, or there may be some changes in the questions. So help me out here, let's discuss the questions and let's derive at the best possible answers out of them. So I would encourage maximum participation from the students for this session. So the first question which I have is, a 30-year-old patient with history of some flat lesions near the anal canal, rashes on the body, hair loss that follows a particular pattern as shown in the image. So what's the diagnosis for this? So now there are a lot of pointers here, quite clear actually. So when you look at the image, it can be anything. It is basically a differential of patchy alopecia, right? And we know that there are various differentials which are there for patchy alopecia, Tinea capitis, alopecia areata, moth-eaten alopecia and trichotillomania. These are the four main patchy alopecias DDs which we have studied. Now let's look at the options here and the question. So there is history of flat lesions near the anal canal pointing towards condyloma lata. Rashes on the body, again pointing towards syphilis, and hair loss that's following a particular pattern. Now what is this pattern? You see numerous patches of alopecia which looks like as if a moth has eaten the hair. So this is moth-eaten alopecia. So this is moth-eaten alopecia, and where do I see it? I see it in secondary syphilis. So Tinea capitis, the first option, there would be some itching, some scaling. Alopecia areata, if there was just this clinical picture, I would not have been able to differentiate it from alopecia areata. But history of rashes near the anal canal, rashes on the body, strictly they all point towards evidence of secondary syphilis in the body, and we know that secondary syphilis can present with moth-eaten alopecia, and so that is what we see here. Right. So was this the same question and was these the options, or do you have any other options here? Okay, so I think the similar history question I would be discussing, that's the separate question. This is the another question that I got. So I have another question on patchy alopecia where there is history in relative, but this was a separate question, I guess. So any other inputs for this question before I move on to the next question? Did we have any other options, or was there anything else in the history? Great. So in case there is anything, you can write it in the chat box and we can come back to this question. The next question was that a 23-year-old patient complaint of a painful rash near the genital area as shown in the image, and you had to tell the diagnosis. Now, a painful rash in the genital area, and look at the image. The image shows a baseline erythema with overlying vesicles. So, baseline erythema with overlying vesicles which was painful. Most likely the diagnosis is herpes zoster. Now, what confused me here were the options. So, probably either it was a lesion like this, or you were given an image of the genital area and talked about herpes simplex. Now, if herpes simplex was to be asked, they would have given you again vesicles with some coalescing erosions. So, but if I look at the option chancroid, syphilis, LGV, none of them will present with vesicles like this. On top of it, syphilis is never painful. LGV would usually present with lymph node. Chancroid will present with ulcer. So, here I am seeing vesicles and painful rash. So, I know either they are talking about herpes zoster or herpes simplex. Now, what exactly was it will depend on what image was given. If this was the image, I would say herpes zoster would be the answer. So, again I will wait for your inputs. Is there anything that you want to add up to this question, any options or anything else which was given in the question, or was the image different? So, if you can help me out here, what's the image of herpes zoster, or they had given you a herpes genitalis image? Okay. So, similar image was given, and I think the options were also similar. So, the question would have been quite simple then. Great. So, thank you so much for giving me this input. So, with this question, herpes infection is the answer, and more specifically herpes zoster if that was there in the option. So, very easy again, painful rash, coalescing vesicles, all this helps me. So, moving on to the next question. Identify the mark structure shown in the diagram. So, you were probably given a diagram of the skin, epidermis, dermis with a hair follicle, and you were given a gland which was opening into the hair follicle. So, we have talked about different glands. We know that there are eccrine glands, there are apocrine glands, and there are sebaceous glands which are there. So, which one of them opens into the hair follicle? It is the sebaceous gland. It is the sebaceous gland. Now, this muscle here is the erector pili muscle. Sweat gland, which is usually the eccrine sweat gland, opens directly into the skin. It does not open into the hair follicle. And what is the skin papilla? So, this is erector pili. Sweat gland is not mentioned in the image here. Hair papilla is this structure. So, the structure, if this was pointed out, it is clearly sebaceous gland, right? Okay, so okay, they did not mark the structure of the gland. 4 marked part were there, and they asked to label all of them. Perfect. So, okay, so they asked you to probably label different parts of the hair follicle. Again, it would have been easy for you. So, this is the erector pili muscle, this is sebaceous gland, and then this is my hair, the upper part of the hair, infundibulum and isthmus, and the lower part here you have the hair papilla. This is my suprabulbar area. So, was anything else asked which I have not covered, or which was different, which you could not understand? So, you can tell me about that. Glands were asked, okay. So, glands we have discussed. So, sebaceous glands, you know, if they had wanted to ask about eccrine sweat glands, they would have put something like this. So, a gland which was opening directly into the skin surface. So, this would have been my eccrine sweat gland. So, thank you so much. So, you were given a question where you had to label basically my hair follicle and the glands opening it, or you were told to label the various glands, right? Eccrine gland was there. So, eccrine gland would have been something like this. It would not directly open into the hair follicle, right? So, I hope it was clear. There was no confusion there. If there was any confusion, please put in your doubts here. If there was any option which you did not understand or something which was different, you can put it here. Eccrine gland would be something like this. Great. So, thank you so much. So, here you told me you had to label the diagram. So, should we move on to the next question? Now, this I would need some inputs from you, because I think I do not have, something is not right, but whatever I have, I will try to discuss it based on that. So, there is a 38-year-old patient with hypopigmented anesthetic patches, and these patches were sent for biopsy and intradermal antigen testing. Using the image below, pick one correct statement regarding the condition. So, I have already told you, if there is hypopigmented, hypoaesthetic or anesthetic patches, I know we are talking about leprosy. So, in leprosy, it is all about knowing the spectrums. Okay, so fourth option was probably lepromatous leprosy with negative antigen. Perfect. Any other change? They did mention nodular lesions in the question, and okay. Okay, I am getting variable responses. Can any of you just sum it up? If you remember the exact question, can you just write the exact question? I guess the options were something similar. One of you is also telling me that probably there was an option of ENL given. Okay, was image, what was the image given? Was it a histopath image? Was it a clinical image? Can you help me out there? Okay, so you are telling me there were probably nodular lesion. I'm just waiting to complete the question and then I'll discuss it out with you. Histopath image was there. Okay, and if you can tell me what was the histopath image like, because you're telling me probably it was not this. Okay, so even with this information, okay, solitary nodule. Are you sure it would be a solitary nodule? Now see, I'll explain you why I'm asking. So see, we know it's leprosy. Now the whole idea is to find out whether it is tuberculoid, lepromatous or in reaction, right? So what would be the various things? The intradermal antigen test that they have asked you, you all know it is negative in lepromatous pole and positive in tuberculoid pole, right? So, if there was any option with lepromatous with positive antigen test, that's out. Now, we have to see whether we are talking about the lepromatous pole or tuberculoid pole. If they had written anesthetic, so there is a difference between hypoaesthetic and totally anesthetic patch. Anesthetic patch is more common in tuberculoid pole. In lepromatous pole, you usually get glove and stocking anesthesia. However, nodular lesion is a feature of lepromatous pole. You do not usually see nodular lesions in tuberculoid pole. So, there is, I think, a lot of confusion here and I am getting variable responses. ENL would have negative tuberculin test, but ENL would not present with a single nodule. So, two option for lepromatous leprosy with positive antigen and negative antigen, and one option for tuberculoid leprosy with positive antigen. So, this though is incorrect. Now, the fourth option was probably, so there was no borderline leprosy, I hope. So, I will cut this option. So, probably the four options were this, right? So, out of this we have to figure out whether it was A, C and D. Now, to figure that out, we have to know either the clinical feature, the exact clinical feature or the exact histopath feature. Okay, so you are telling me there were only nodular lesions and it was not written whether it is solitary or not. Okay, so now if nodular lesions was there, I would also rule out tuberculoid leprosy, because tuberculoid leprosy does not present with nodular lesions. It would usually present with a plaque, a single plaque or 1 to 10 plaques. Right. Nodular lesions with some anesthesia written. Now, so we are left with two options, lepromatous leprosy with negative antigen or ENL with negative tuberculin. What was the histopath like? Okay, so I've cut down borderline. So thank you, Dr. Lokesh. I've already cut down the option of borderline. Nodular lesion with anesthesia over arm and involvement of ulnar nerve. So see, if there was anesthesia over arm, they are probably talking about glove and stocking anesthesia. So we know we are heading towards lepromatous leprosy. Also nodular lesions can be seen over lepromatous leprosy. Now if they want to ask about ENL, they would give you certain features like constitutional symptoms, fever, the existing lesions, they develop nodular lesions. So if they are talking about, and what was there in histopathology? In lepromatous leprosy, in histopathology, you would see a Gren zone, you would see an infiltrate which has a lot of macrophages, can be foreign body giant cells. So was there anything like that in histopathology? Okay, so I think what we get till now is you got some nodular lesions which were hypoesthetic along with anesthesia over the arms with ulnar nerve anesthesia, and they gave you a biopsy. Did they mention anything about the reaction in history or in histopathology? That's my last question to you. And if there was none, then obviously the answer would be lepromatous leprosy with negative antigen. But if there was some mention of reaction, some mention of painful nodular lesions, crops of nodular lesions or evanescent lesions or constitutional symptoms. Right. So I think we complete this question here. I will come to the first question later, but let's complete this here. So probably the question was a patient with hypopigmented or not hypopigmented nodular lesions which were associated with anesthesia was given. They had given you a biopsy image and they have told you about intradermal antigen test, and you had to identify what spectrum was it. Now, since there was nodular lesion, since there was anesthesia over the arm, we will rule out tuberculoid pole. Now, the second option, which was lepromatous leprosy, we know it does not have a positive antigen test, so that's also ruled out. We are left with two options, lepromatous leprosy or ENL, both with negative antigen test. We know that both of them have negative antigen test, but if they have not mentioned any feature about reaction, lepromatous leprosy can present with nodules, and so it can present with anesthesia over the arm with ulnar nerve involvement. All of this can be present, and so I would mark lepromatous leprosy with negative antigen here, unless there was some feature of ENL which was mentioned, which you guys are telling me was not there. So clear? So I think then it was not so confusing and you would have marked the correct answer. Right. So thank you so much. I think we do not have any more inputs for this question. So moving on to the next question. Picture an accurate diagnosis using the histopathological image shown below. So one question about box-shaped lesion. Is this the one that you're talking about, Dr. Lokesh? Okay. So Dr. Vishal is telling me that there was an image which shows Gren zone. If there was Gren zone present, then again the diagnosis become easy. It is lepromatous leprosy. Okay, was this the... No. So see, if they had given you something like this, what is it that they are pointing out to? Was this the same box and was this the same image which was given to you? Was there any other input in the question? Because if this was the image, then what are they showing in the image? They are showing this sawtooth thing. They are showing this sawtooth image, isn't it? The histopath image which has been provided is a very low power image. on the basis of it, it is not possible to, so I think, wait, sorry, if they had given you this is sawtoothing that has been provided, and sawtoothing is seen in, sawtoothing of rete ridges is seen in lichen planus. Some of you are telling me answer as morphea. Dr. Ashish, Dr. Lucky, can you help me out here? Why are we thinking about box? Okay, so have they mentioned something like box shaped lesions? Because in dermatology per se, we do not refer to anything as box shaped lesions. When I looked at it and I had no other information, I thought they are trying to point out towards this thing, that this sort of thing. I'll wait for, was it box shaped lesions or lesions which resemble this thing? Because even for morphea, you do not say box shaped lesions, they are not box shaped actually. Morphea would be more indurated, more fibrosis, and okay. And were the options similar, lichen amyloidosis, lichen planus, nitidus and morphea? See, because based on this histopath image, there it's a very low power view. Yes, it shows a lot of fibrosis, but the epidermal changes are hardly clear to make a diagnosis of what it is exactly. Now, this box thing which shows sawtoothing is something which you see in lichen planus. So, that is still a possibility, and you do see in the epidermis, if you look at the rete ridges, you are seeing sawtoothing. So, I think based on this question and based on this image, the answer should be lichen planus. However, if there is any correction in the question, I would wait for your responses, and if there is any other thing that I get to know, I will inform you in due course of time, right? Okay, moving on to the next question. Again, I would need your help here. So, I have probably a 25-year-old patient who presented with rashes on palms and body. Frame a diagnosis using the histopathological picture given below. Somehow you got a lot of histopath images this time. So, I hope it didn't confuse you. Again, I know this may not be the exact histopath image or the clinical image. So, I would need some help out here. What was the image of? What was the histopath image like? Okay, thank you so much, Dr. Lucky. I think we'll get back to that question. I would get back to you with the correct answer, even if there was box-shaped lesions. We'll just try to figure out whether there were any other options which were mentioned, or there was a better histopath image which shows something better. While making the smear and seeing it outside the microscope, while making the smear or histopathology, and seeing it outside the microscope. See, morphea will just present with a dense fibrosis. In the initial stage, in the inflammatory stage, you see inflammation, and then there is dense fibrosis. So, if they had asked you ki outside microscope image, then they were showing sawtoothing, and sawtoothing is seen in lichen planus. So, then that's done. Okay. So, there was thickness of palms and soles, very good. So, I hope there was some thickness of palms and soles which was there. So, if there was this thickness of palms and soles with some rash on the body, with a histopathology which showed a psoriasiform hyperplasia, you see this? This is camel foot appears, some psoriasiform hyperplasia, but you do not see any parakeratosis. So, thickened palms and soles, rashes on the body, and a histopath which broadly showed psoriasiform hyperplasia, then I would mark PRP as my answer. Now, I was only confused whether they had given you the thickened palms and soles. How was the body image, if it was like PRP or like psoriasis? So, option was follicular psoriasis, okay. So, follicular psoriasis would not present like this. Thickness of palms and soles was mentioned. Scaly lesion was mentioned. There was was there disc keratosis or alternate hyper and parakeratosis? Orange hue. Perfect. So, if there was orange hue mentioned in the question, if there was thickness of palms and soles, and if the histopath was something similar to what's seen here, then PRP would be the correct answer. Follicular psoriasis will not present with palmoplantar hyperkeratosis, would not present with a diffuse rash. Cutaneous T cell lymphoma, again no hyperkeratosis, and in the histopath image in CTCL you would see microabscesses in the epidermis. You know that Pottier's microabscesses, which is not seen in the histopathology image here. Plus, orangish hue is very, very classical of PRP. Orangish hue, thickness of palms and soles, psoriasiform hyperplasia with alternating hyper and parakeratosis is a feature of PRP. Very good. So, if hyperkeratosis and parakeratosis was there in the option, parakeratosis or orthokeratosis was there in the option, then we know that it is PRP. I think then it would have been easier for you to answer, right? So, I hope there was no confusion here then. So, probably in the question they had mentioned that there was hyperkeratosis or orthokeratosis, and maybe they had mentioned alternating hyper and parakeratosis, right. So, coming to the next question then, a patient presents with a nodulo-ulcerative lesion on the lower lip as shown in the image. I am sure this was not the image. Nodulo-ulcerative lesions would look different. What is the best way to take a biopsy in this case? So, if this was the question, just to clarify, if there is some nodulo-ulcerative lesion on the lower lip, we are thinking of actinic keratosis or some SCC precursor, and so there we would try to take the complete biopsy rather than taking a punch. So, I had told you that whenever we are suspecting any malignancy, we try to go for excision biopsy. So, I think that would be the answer here, but again I would wait for if there were any other options, if the question was different, options were different. So, yes, probably the questions are a mix of shift 1 and shift 2. So, again you've done your paper, you have done whatever was asked to you. So, do not get confused now that did I miss out on this question. I am sure there were 2 shifts. So, there may have been different questions there. Okay, so coming back to the question here, is there any inputs that you guys have on this question? A patient presenting with nodulo-ulcerative lesions on the lower lip. Did it ask what is the diagnosis? So, then if it asked what's the diagnosis, what were the options that were given to you? Was the image similar? So, if they had mentioned nodulo-ulcerative lesion, we know that we have to biopsy the complete lesion. We will go for excisional biopsy because we are thinking of precursor lesion. Okay. So, ranula, if there was, so you've changed my question and my options. If they had just asked you the diagnosis and the image was something similar, then yes, ranula can be the answer. Okay, any more inputs on this one? Right. So, I will move on to the next question. A farmer with a history of prick injury presents with multiple discharging sinuses. A farmer, prick injury, multiple discharging sinuses. Very clear, we are dealing with mycetoma. Now, what do I see here? During the staining procedure, a filamentous organism was seen. So, we know mycetoma is caused by actinomycetoma and eumycetoma. Let us look at the option here. Sporothrix. Sporothrix does not lead to multiple discharging sinuses. Histoplasmosis again does not present like this. Nocardia. Nocardia does lead to actinomycosis, actinomycotic mycetoma, and so that could be the answer. Cutaneous leishmaniasis again presents with crusted lesion, does not present with multiple discharging sinuses. So here again the options were quite clear, and image was mucus cyst and excision. Okay. So yes, okay. So if the image was of a mucus cyst and they had asked you what will you manage, again you will do the excision. So probably they did not ask you about the biopsy or a nodulo-ulcerative lesion. They had given you a swelling or a cystic lesion on the lips and they had asked you what will you do about it. So yes, excision would be my treatment of choice there. Okay, thank you, Dr. Akriti. The patient had a nodular lesion of his arm. So again, that remains the same. Dr. Priya, the image was mucus cyst and excision. So yes, if there was a mucus cyst and they had asked you about the treatment option, it would be excision. So about this question, I think there are no controversies with this question. You were given a clinical image or a clinical picture of mycetoma and you were asked the organism. So we know actinomycetoma causes mycetoma and actinomycetoma is caused by nocardia. So nocardia would be the answer here. Clear? So let's move on to the next question then. Identify the condition using the immunofluorescence pattern. So very direct question. What do you see here? You see fishnet pattern on DIF and we very well know that fishnet pattern is seen with Pemphigus vulgaris. So I hope there was no confusion in this one at least. You were given a fishnet DIF pattern and the diagnosis was Pemphigus vulgaris. Which was another question about mucus cyst or mucocele. Okay, so probably there were two questions as you were telling me. So the image that I put was of one question and the question was different. So nodulo-ulcerative lesion, if it was present, we are clear, we'll do an excision biopsy and probably you were given a mucocele or a mucus cyst and asked what is the diagnosis, what is the treatment option. So thank you so much, and if this was the image, very clear fishnet pattern in DIF and that is what you see in Pemphigus group of disorders. So Pemphigus vulgaris would be the correct answer. Okay. Thank you very much Dr. Amrit for clarifying two questions, one on ranula and one on SCC. Clear. So I think this is another question which you guys were mentioning. A 5-year-old child presents with focal area of hair loss as shown in the image and this lesion. So again I have a patchy hair loss associated with scaling and itching. There is a similar history in sibling 2 years back or 2 years old, I am not sure. So identify the condition. Very easy. I have a patchy alopecia with scaling, with itching, with a positive family history. I know I am dealing with Tinea capitis. Clear? So I think this was one of the questions which you guys were talking about. Even if there were multiple patchy hair loss, so yes, 2-year-old hoga in the sibling who's 2 years old. So family history, itching, scaling, focal areas of hair loss, we know we are dealing with Tinea capitis. So answer would be simple, Tinea capitis. So okay, there were multiple patches, even then my answer does not change, right. So thank you so much for this one at least. Okay, thank you Dr. Amrit. So the same question was there, but probably you had multiple patches. We know Tinea capitis can also present with multiple patches. It's not like you have to have a single patch here. Great. So next question, the drug to be given in a 25-year-old male with acne as shown in the images. Now I am sure this must not have been the image, but what I am guessing that probably they give you an image where there was truncal involvement, face involvement, and on the face you could see scarring or nodules, and we know that according to that the treatment would be systemic isotretinoin. Because I don't minocycline and doxycycline, there are no two different conditions where I have to mark both of these. So these are antibiotics which are used in grade 3 acne, but probably in the option most effective drug was asked and we were given nodular involvement of the face. So if there was nodulocystic involvement of the face, we know that the best option would be systemic isotretinoin. So, I do not think so there is any confusion regarding that. It was easy. Okay, then there was a hair shaft with arthroconidia as seen in the image below, and you had to identify the fungus associated with this. So, even when even if dapsone was there in the option, you would mark systemic isotretinoin. Now, in this image what I see is, I see a hair shaft and I see lot of spores inside. So, if this was the image, it was endothrix that they had given you. Now, out of these options here, we know epidermophyton does not affect hair. We are left with trichophyton and microsporum, and we know trichophyton leads to endothrix infection and microsporum leads to ectothrix infection. So, if this was the image, this is an endothrix, so my answer would be trichophyton. Okay. There was history of tobacco and there was growth inside lip, and they gave option superficial biopsy and also of surrounding tissue, and other option deep biopsy of only growth. So, you will never do a superficial biopsy. You would go for a deep biopsy because you have to look at the deeper margin. So, if this was the option in the deep biopsy, they are not even given you surrounding tissue, you will still go for deep biopsy. Right. It was trichosporon, there was history. Okay, so trichosporon. Anything else? Any other option? What were the other options apart from trichosporon? Was the image similar? Was the question similar? I get it, students, that there was no trichophyton, but what was the other option that you were given? I just need to know whether the options were different, there were any other options, or whether ectothrix, endothrix was given. Okay. Similar enlarged ream. So, see, in this case, we know that a dermatophytic infection can lead to ectothrix, endothrix, and tinea is nothing but Tinea capitis, and Tinea capitis can present with endothrix and ectothrix. So, if tinea was there in the option, you could have marked tinea also. Tinea means dermatophytic infection. Tinea can be Tinea capitis, and Tinea capitis can be ectothrix and endothrix. However, it is difficult to believe that they gave you this endo and ectothrix and they did not want you to all right. Fine, then we can mark tinea if you did not have any other options which were valid here. So, this is all that I have, and I think there was penile discharge. So, probably urethral discharge question was there and you were asked about the treatment. So, that is probably a question that was given from the STD kit. So, we know that urethral discharge is managed by kit 1. So, thank you so much. So, grey kit, yes, kit 1, which is the grey kit. Okay. So, I think this is it. Any other questions that you have for me? Otherwise, we wrap up this session. I already answered this, the tobacco one. So, probably I missed on this question, urethral discharge and STD kit was asked, kit 1 or grey kit. Or yes, so you all know that kit 1 has cefixime 400. So, even if that was there in the option, you can mark that. So, I think I'll wrap up my session here. Thank you so much for all your inputs and all the best for your results. I'm sure you do very well.